So welcome everybody who's being brought into the webinar session. My name's Morag Farher. I'm Professor of Palliative Care Research at University of East Anglia, and I'm just giving you a very brief introduction before I hand over to Ben Bowers, who's chairing this webinar. So Ben and his colleagues are going to be talking about timely access to end-of-life medication. But just to introduce you to the webinar series, if you're new to them. So this is from the NIHR National Cross-ARC Palliative and End-of-Life Care Collaboration. The NIHR funded 15 ARCs until March 2026 to conduct applied health and social care research where it's needed. And this National ARC Palliative and End-of-Life Care Collaboration is co-led by Professor Irene Higginson from the South London ARC and myself from the East of England ARC, and ably supported by Dr. Meg Hakoglu in a supporting role. And the aim of the collaboration is to drive national collaboration, maximise and deliver impact, and to provide expert advice. Before I hand over to Ben, just a sort of point of housekeeping to say it would be incredibly helpful if you have questions that you'd like to ask today to please put them in the Q&A function on Microsoft Teams rather than in the chat if possible, because it just helps us to manage those. So I'm going to now hand over to Ben and I'll stop sharing.
Thank you, Morag. So, hi everybody, lovely to meet. I'm Dr. Ben Bowers. I'm an assistant professor of primary care at University of Cambridge, and I lead a program of research focused very much on how we can improve medication access at the end of life and ensure timely and effective and safe symptom control care. I'm also the deputy theme lead for the ARC East of England Palliative End of Life Care theme, and that's enough titles for me. What we're going to do today is, when colleagues said, Ben, could you organise do something about how we can ensure timely access to medication, I immediately thought of three sets of people I really wanted to hear from. So what we're going to do is we're going to have three speakers, all from different centres, sharing very innovative work they've recently been doing. And we're going to have three presentations, 13 minutes each, back to back. And then after that, we can have some Q&A time. So I'd love for you to, as we go through, as Morag's mentioned, if you could put any questions as they come up to you, or even comments in the Q&A chat as we go through, it would be brilliant. And then after that, we're going to go back to Morag. We're going to finish bang on for 12 o'clock is the plan. So our first presenters who I'd like to introduce are Sarah and Sally Ann, who are from UCL, and I'll let them introduce themselves a little bit further. Only their colleagues I work with very closely, and they do amazing work in the medication space.
Thank you very much, Ben. It's really great to see so many people here, although now I've started sharing my screen, I can see less of you. Sally Ann and I are going to do a joint presentation on behalf of our wider team, who you can see listed on this slide. And this is sharing work we did to highlight critical gaps and also get better understanding of how we can reduce gaps between workers intended or designed and workers done or experienced in palliative medication management. And you can also see we're really keen to make sure we looked across all settings and that we focused our study on how we could improve patient safety and carer confidence. So, as I'm sure this audience is aware, medicines management is a complex, multi-step social process. And yet often our guidelines and protocols are written a little bit more like the A to B inside the box, whilst those of us out in the real world are wondering exactly which way to go with things. It involves multiple people, practicalities and places with lots of different levels of decision making by those different people. There are both acts, things people do, and artifacts, things people work with in relation to medicines management that can be complex. And underlying all of that, the meaning making that individuals are undertaking as they personally balance their own views, their own mental models of the risk of harm versus the potential of benefit, influences how everything does or doesn't work together. So when we were designing our study, you can see the goals that we had, and we will explain these a little bit more as we go through. We tried to think about the different types of gaps, and the diagram on the left here is sort of where we've arrived at. So you can imagine if you had infinite resources, you could design an ideal system for palliative medicines management. But we all know that there aren't infinite resources. So there is always going to be a pragmatic design gap between what is ideal and what is intended. However, perhaps more problematically, because that design gap can be made transparent and clarified, there is also a delivery gap between what's intended, so what happens on paper, the design, and what actually happens in real life, the experience. And this delivery gap is often the gap between policy and practice, rhetoric and reality, expectation and experience. But there's also another gap that's really important not to overlook, and that's the gap between what actually happens in practice and what really would be ideal. And often that gap is filled by hidden work, and we throughout the presentation use work in the widest sense, meaning any activity that anybody undertakes, not just paid employment. And this is where we really focused, trying to understand what are people doing to mitigate things in the system that don't work, and how can we look at multiple perspectives to improve the system, and how can we also think about both hot and cold spots, because there are some things that are problematic and very much talked about. Syringe drivers, I'm sure everybody on the call will probably recognise that as an example, but there are also things which are less talked about but still remain very problematic. So as we go through our short presentation, we decided we would focus on our findings and how we've worked with clinical teams, patients and carers to create impact rather than our methodology. But if you're particularly interested in the methods or the stakeholder engagement work that we ran in order to design the study, you can scan these QR codes now or when you get the recording later. Just want to thank Joe, who worked with us here to really make sure that from the very beginning everything was underpinned by stakeholder engagement, and also the many people from lots of different places in the system and lots of different roles who helped us refine the toolkit we've produced as a result of this study too. So I'm now going to hand over to Sally-Ann to give you a little bit more detail.
Thanks, Sarah. So we started by undertaking a scoping review. We wanted to develop a map of intended processes when palliative medicines are prescribed or used for symptom control. So it was mapping out what happens on paper. We looked at over 20,000 articles, and we found that most evidence actually lacked the process detail, but 96 provided us more rich data in order to build the essential elements of our intended processes model. Obviously not time to go through the detail today, and there will be QR links if you want to interrogate it a little more at another time. But elements were grouped according to the following themes. So we had an underlying group of artifacts which supported medicine's use. And then we've grouped things according to expertise and judgment, supply and access, administration, monitoring and review, and medicines optimization, so involving prescribing, de-prescribing, rationalization, all kinds of decision making around prescribing. Throughout our looking at the 96 data-rich papers, we also identified a number of add-on elements from individual authors' work, which we felt could potentially create almost an ideal system. So additional things such as the roles and relationships between generalists and specialists, who does what, thinking about proactive planning for prescribing across boundaries, and then the practical challenges associated with urgent medication needs from all different perspectives. So while steps were discussed across different papers, a whole systems approach was not explained. Next, please. We followed our scoping review with a piece of empirical work, an ethnography, where we where we undertook 120 hours of observation in hospital, hospice and community settings, so approximately 40 hours in each setting. We undertook 83 interviews with patients, carers and a whole range of professionals, which are listed there, in each of these settings too. Next, please. So this is just your warning for our next slide. So this is our whole systems map of real processes. So this is reality. Again, we don't have time to go into it in detail, but I'd encourage you to have a look through the QR codes at the end. To give you an essence of it, we start with a button on the left-hand side, and then there's a series of steps when a person is admitted to hospital, which maps out all the individual steps and activity in their medication journey. So these steps 1 to 10 are repeated each time a new medicine is started. And then the same process continues in the community after the person leaves hospital. And indeed, it can start again if they have a new inpatient stay. At each step, the model highlights who may be involved, the patient, the carer, the healthcare professional, when pharmacy staff or services play a key role, what tools or items are important at each step, and what could potentially improve the system. Again, helpful additions that we found through our empirical work that are not yet standard practice. So, for example, an improved understanding of palliative care practice across the system, perhaps an acknowledgement of the symbolic significance of different medications and equipment for patients and carers, or things such as support for patients and carers around those micro decisions around medicines management. Next, please.
Okay, so we wanted to illustrate what Sally-Ann's talking about with an example from our data. And I'm again giving you the context of the data, but really want to just highlight a few themes. So this is a story given to us by a carer. And you'll see where the title comes from shortly. But you can see in this first extract how there was a significant burden of medicines management. She talks about her role being very involved, the terrifying bag of anticipatory end-of-life injections, no one to ask. And towards the end of the text here, having gone beyond being able to keep track, having had multiple systems of her own, but just finding it very difficult in a stressful and sleep-deprived situation. We also see that safety was very much a human-dependent outcome rather than something inbuilt necessarily to the system. Here the carer talks about a good relationship with a pharmacist, but describing her as going beyond the limits of what was reasonably her duties to ensure that safety was maintained when the structures were perhaps failing. I'm sure everybody recognises that it's not just a task or a transactional thing that carers are doing, but very much emotional work in their caring role. And here is where she talks about feeling like she didn't know whether she was doing the right thing, trying to get her mum to take medications, but feeling as if though she was in an Agatha Christie story, that the trying to administer some poison, trying to get her mum to take something which she did believe was good for her, but that had become more and more difficult to explain to somebody living with dementia at the end of life. Her role was also very ambiguous, and I think this is one of the things we see time again that carers find hardest. She is talking here about an admission to the hospice and having to be really insistent that she needed to be with the doctor because she knew what the actual medicines were and how they were actually being used. And at the same time, this carer is very generous, saying, you know, she understands that the staff were trying to relieve her of some of the burden, but that in itself is a difficult thing to be able to do, and not feeling like they were necessarily treating her as someone with legitimate knowledge in the system. And then when we get to after her mum had died, the burden of what now, and nobody really explaining that to her. So you can see there some of the themes that were coming out. And what we did was we took activity theory model, which this is illustrated here, and mapped those to what are the different bits of what is making up the system, and included in that things like both the formal rules but also the informal, how things work around here, who's involved, how is work or labour divided up, and how is that negotiated. And you can see a quote from a professional here talking about any of the links can result in unintended serious consequences. So to give you some more examples, when we were looking in our data for how things work, we identified these sorts of quotes when we were looking at distribution of labour, when we were looking at who was involved, and also the things, medication charts involve an awful lot of work and cause people an awful lot of angst. And having done that, not just with this story, but with the entirety of our data, we pulled out some themes that help either maintain or hinder that and in loss of the goal of getting medicines right occurs. So first of all, in maintenance, the sustained investigative work of checking and chasing that everybody in the system undertakes. Having a sense that within your identity, whether it's a professional role or as a carer or a patient, you can flex and you're free to get things done. And the hidden work and responsibilities that fill the gaps in structural processes. On the other hand, loss of that goal, often we saw disempowerment by design, where responsibilities were contested, information didn't flow, feedback loops didn't work. Lots of cycles of assumptions about assumptions. So people self-editing their behaviour because they were concerned about what somebody else might think of them. Another person in our study talks about the need to be perceived as a good patient, not someone causing trouble, but also assumptions between professionals across the different settings about how things might work in other settings. And that leads me to the third one we picked out of transition inadequacy. So often people were transmitting information, but the lack of dialogue meant that there was no one overseeing the actual continuity as somebody moved between different care settings. And across all this is underlying the problem of practice etiquette, how things work around here. And that's where we then focused more on the hot and cold spots I referred to earlier. So you can see here a summary of those hot and cold spots, and we're very happy to talk in detail about them. But I would just, in the Q&A, but just highlight to you the things that are in the cold spots particularly, that perhaps need greater attention if we really want to improve the work of medicines management and make it a better process for everyone involved. And therefore, in terms of our overall analysis, we really want to highlight the importance of relationship-centred system design, because it's the breakdowns in the chains of activity, not just the individual tasks, that increase risks. That currently there's a shadow system that very much involves patients and carers developing out-of-system workarounds, but also professionals entering what we're calling fictional contracts, which is a concept to describe saying that you're doing your work in one particular way because that is what the rules demand of you, but actually engaging in it in a very different way to fill gaps in the system. A lack of trust in systems also means that the shadow system isn't fed back to policymakers, and therefore they're not able to make helpful improvements. And that's something else that we really wanted to highlight as coming out of our findings. So we need to improve system facilitators for collaborative working, and we would suggest a relational approach could actually reduce overall workloads and create greater whole system effectiveness. So I'm going to hand back to Sally-Ann to just give you a few comments on how we've worked with teams to put this into practice and create impact.
Thanks, Sarah. I am aware of time, and I think we're probably pushing our 13 minutes. So just to say that we produced a number of items or products from our research, and we used those as a toolkit. We took this out to 4 different Marie Curie places to develop quality improvement work. And if you want to know more about what happened in Bradford, Glasgow, Devon and the West Midlands, very happy to talk some more about it. But if Sarah, if you want to go to the final slide, there's QR codes for people to look at our toolkit and to get in touch with us for more information. But thanks very much for your time, and I'll hand back over to Ben.
Brilliant. Thank you, Sally Ann and Sarah. Excellent work and a really great overview and insights there. I'm going to move straight on to my next speaker. And for people who have joined us a little bit later than our start, we can have our 3 speakers back to 3 sets of talks back to back, and then we're going to have a Q&A session. So do put any questions you've got as we go in the Q&A chat, please. So over to Rosanna, who's at the University of Cambridge, and I'll let you explain more, Rosanna.
Thank you, Ben. I will just share my slides. Okay, can everyone see those?
Perfect.
Thank you, that's great. Good morning, my name is Rosanna Fennessy and I'm a research associate with the Palliative and End of Life Care Research Group based in Cambridge. Thank you for joining today to listen to our presentation on mapping patient and carer experiences with injectable medications. And listening to Sarah and Sally's presentation that they've just had, I'm sure you will be able to see some similar themes coming out in the work that we've also done as well. Okay, so I'm not going to go into the background of this, and you've already seen an amazing slide from Sarah and Sally that talks about the complexity of the intended journey with anticipatory medications. It's a complex system involving those many decision-making points and activities for healthcare professionals, patients and carers. Decisions around prescribing, getting medications into the home, monitoring and use by visiting nurses or paramedics, and even disposing of those medications after death. And what this journey doesn't show is the interactions of patients and carers with health professionals on this journey and how they navigate this complicated journey. So we were interested in looking into that a bit more. So what we did, we borrowed some journey mapping approaches from typically used in engineering and inclusive designs when we're looking at improving patient safety, but they're less often used to illustrate patients and carers' experience of navigating pathways in healthcare. So we looked at some data gathered for another study, longitudinal data with different perspectives based around 11 patient cases. And within those 11 patient cases, we had patients, we had family carers and healthcare professionals involved. And this was done over time, 28 interviews in total. And then our analysis was in 2 stages. First of all, we conducted a framework analysis, and I don't have time to go into the details of that, but again, happy to answer questions or follow up separately. But what we were particularly interested in was looking at some of these journey mapping concepts, and in particular, what we call touch points, so interactions between patients, carers and healthcare professionals, pain points, examples of where, in this case, patients and carers felt their journey with anticipatory medications was not going as well as they had hoped. And also if there were any examples of adaptations, things that patients and carers might do to actually manipulate that pathway to make things easier for them. And across our interviews and our 11 cases, we chose 3 personas. So our personas were real people because we wanted to use their sort of dialogue in our research, but personas can also be amalgams of characteristics. And we chose these 3 to represent, I guess, extremes of different experiences with injectable medications so that we could illustrate that. So people who had their medications prescribed a long time before they were used, people who had them prescribed more recently, differential diagnoses, some people with cancer, some people without, and different personal contexts. Some people who lived alone were unable to advocate for themselves, others who lived with carers who could take that on for them. And then we mapped out, firstly, with post-it pads, post-it notes representing different aspects of patients' experience. And we mapped out the 3 journeys. And on, I don't know if you can see it clearly on there, but the pale blue post-it notes with the black triangles on represent the intended journey with anticipatory medication. So in the particular case of Liam, that I'm going to talk about a bit more in a minute, he came home with those medications from hospital in a bag. But there's also the point at which they are used, whether they need to be replenished, and even how they're disposed of. And all the different coloured post-its, which represent experiences, needs, wishes, pain points, everybody's journey was different. But what we did notice were these 3 recurring pain points across those journeys. And we looked back at our other cases, found those reflected in there. Importantly, we took our journeys to our wonderful patient and public involvement group, which has individuals who have experience of caring for loved ones at the end of life and using injectable medications, and they also could attest that they had experienced these pain points as well. And that's what I want to talk about now. So the 3 pain points, and then I'm going to talk about each of them with one of our journeys. So firstly, perceptions of anticipatory medications, what anticipatory medications are and what they're not. And again, Sarah and Sally-Ann talked about this, the communication about understanding of them. And again, quality of information exchange. So that dialogue between patients and carers and healthcare professionals, and amongst healthcare professionals too, such as thresholds when medication might be used, how patients and carers can get in touch with health professionals to discuss medication use. And finally, how patients and carers navigate these this complex system, and in particular, how it's dependent on their context and how it might change over time. And then I'm going to illustrate these sort of stories now in each case. I'm going to tell you about Liam, who lives with his partner Amelia, Ted, who lives alone, and then Sue, who lives with her husband Marcus. So I'm going to start with Liam, and I'm going to talk to just one of our pain points across our 3 stories, but hopefully if you can see the pictures, and I'll try and make comparisons when I can, that the similar points were recurring across the 3. So Liam, he lives, as I said, with his partner Amelia. She advocates very strongly for him. He's been deteriorating gradually with cancer and heart failure. He has lots of long stays in hospitals with infections. On discharge from one of these visits, he was sent home with what he told was a bag of special medication. No one on the ward was able to explain what they were. So when they got home, Amelia looks in the bag and realizes they aren't the ones that he's previously been given. So she Googles what they are, realizes that they are, for drugs for pain relief, things like that, contacts the GP for some more information. The GP gives her a bit more details about that they would be used for pain and things like that, but says, don't worry about them now, put them in the cupboard, they're for later on when Liam can't swallow. So they're quite happy to have the drugs that for future use at this point. On one occasion when Amelia's out, a visiting nurse comes in and the medications are used with Liam. And when she returns, she's very worried about how sedated and sleepy he is. And when Liam recovers from that, he's also a bit worried about using these drugs because he says, I don't want to be a zombie. And between them, they become increasingly concerned about the potential of these medications for over-sedation and maybe even hastening death. Amelia, one of the quotes from Amelia was, it would be very easy to bump people off with these. So they decide that they don't want to use these medications anymore, and they're going to put them in a cupboard, and it would only be a dire emergency that they would use them again. And in fact, at the end of the interviews with Liam and Amelia, he died 97 days after they were prescribed, and they weren't used anymore. So the reason for showing this journey, I hope you can see, was really related to their sort of perceptions of what anticipatory medications were. Their misconceptions of them not being safe and possibly hastening death meant they made a decision not to use them, whereas they might have been helpful for Liam's journey. second person I want to tell you about is Ted. So he's very different to Liam. He lives alone. He's quite frail, 91 years old. He's bedbound now, can no longer swallow his oral medications. He has frailty and heart disease. And for Ted's story, I want to talk about information exchange. So as I said, Ted lives alone. He has a friend, Sarah, who visits him every day, and his niece also visits. And on one of those visits, Sarah's quite worried about his deterioration and asks a GP to come out and see him. So a GP comes and explains to Ted that he's nearing the end of his life and suggests that she introduce anticipatory medications. She explains them really well, so very different to Liam's experience, very well explained, and says given that he can no longer swallow, they will set up a syringe driver and start these medications straight away. So everyone's very happy with that, and Ted's niece collects the medication from the pharmacy. But Ted lives alone, so he has visiting nurses every day, and when they come in, they don't see that Ted's in distress and in pain, and so they don't set up the syringe driver, and he doesn't get any of the medications. When Sarah and the niece visit, they're increasingly frustrated. They do think he needs the medications and don't know why they haven't been set up. So what they talk about then is the challenges they have trying to communicate with healthcare professionals when they're not there, when they actually come round. So they talk about going through to call centres, not getting particular answers from people, and a real sort of like sense of a lack of communication and dialogue. And they talked about how frustrated they became with this and felt, you know, really unhappy that they felt Ted wasn't being supported. In the end, they adapt the medication systems themselves. They've got some Oromorph in the cupboard, so they give him that as they feel that's the only thing that they can do to help him. And Ted died 5 days after the medications were prescribed and they weren't used or the syringe driver set up. And Sarah was described the medications as useless because no one would give him anything. So you can see here, so the quality of like information exchange between the patients and carers and trying to get in touch with those nurses about why they weren't prescribed, and particularly that discrepancy between the GP saying one thing to them, which is what they thought would happen, and then their actual experience, and no one sort of trying to bring those two different views together. And then finally, I just want to talk briefly about Sue. So Sue, she lives with her husband, Marcus. She's fiercely independent, advocates for herself. Marcus definitely kept at a distance with this. She doesn't want him involved in anything to do with her care. Her medication actually arrives with some district nurses. She doesn't know who prescribed it. And she also said they weren't explained, but Sue was a nurse, so she has an idea of what these medications were, and she thought they were good for future use. They were actually used for Sue when she had a bout of sickness, and she felt they didn't work for her at all, and then eventually she was admitted to hospital, and she thought there was perhaps a bit too much emphasis put on what these medications could do when she needed another kind of support. But what I want to draw out in Sue's story is what happened to her later on her journey. At the beginning, she had very much told health professionals she didn't need their input, that she would contact them when necessary. But as she deteriorated over time, she found that increasingly difficult to navigate that pathway. She tried to get some help for some medication-related constipation, talked about challenges of ringing 111, trying to speak to pharmacists, computers not working, and things that she could have managed easily at the beginning of her journey became increasingly difficult. But there was no follow up with those health professionals to step in and assess that increasing need for support for Sue. And at the end of the interviews with Sue, this was, I think, 123 days since her medications were prescribed. She was still alive on her last interview, and those medications haven't been used again. So I've rattled through those in a very speedy way, and I hope you could see those points being illustrated across. But what I wanted to just bring towards the end is just by identifying those pain points for patients and carers, it does highlight those opportunities for improvement. So firstly, those explanations of anticipatory medications, what they are, when they might be used, and a realization that everybody's experience is so different. So if you come home with medications from hospital, you perhaps need that to be dealt with differently to if they are being prescribed arrived, and then a nurse is coming in to talk about them. Optimizing system transparency, but really just making sure there are clear pathways for contact and explanations. Certainly in the case of Ted, who didn't have anyone in the home to speak for him, to talk to those nurses, that was absolutely critical, that maybe a different system was in place for him as for, say, Liam and Amelia, that were able to manage this themselves. And finally, that tailoring that input. So, there is no one size fits all here, and sort of being mindful of people like Sue, who deteriorated over time and needed greater support. And then finally, and I think this is one of the things, I have not done any work like this before, this creation of these personas, and whether they're real people or amalgams, and then mapping journeys experientially. I hope you'll think it's actually a really useful and interesting way of incorporating patient voice, and for looking at the in some similar ways to Sally and Sarah's work, the difference between an intended pathway with something and the actual experience of patients and carers. And then just finally, thank you to Artemis and Ben Bowes, who also worked on this, and our wonderful patient and public involvement group. And just, I'm going to have about a second with this up, just some quotes from our three participants who became our personas, from Amelia saying how easy it was to bump someone off, quality of information exchange about the frustration of Sarah, and then again, poor Sue trying to navigate these systems at the end. Thank you.
Brilliant. Rosanna, it was excellent. Thank you ever so much. And it's been a true pleasure working with you on this. For me, it's been pushing different methods as well. And I think there's applications here for many other things, as you described, to understand work as experienced by people rather than the intended pathways we think people go through. There's a couple of questions for you which we're bringing to the Q&A session, but I'd like to bring it over to our third speaker now, over to Akumi, representing University of Edinburgh and also presenting a major piece of Marie Curie work. So over to you, please, Akumi.
Yeah, thank you. Am I sharing them okay?
That's perfect.
Yeah, okay, thank you. Yeah, so good morning, and thank you for the opportunity to present our work today. I am Ikumi Okamoto. I'm presenting on behalf of the Marie Curie Better End of Life Research Team, a collaboration between the University of Cambridge, King's College London, and University of Hull. So today, I will show findings from our UK-wide qualitative study about why timely access to out-of-hours end-of-life medications is so difficult, and how some local teams are addressing it. So this work was part of the Better End-of-Life program funded by Marie Curie. And this talk is based on our recent paper published in the British Journal of General Practice. And you can access full details if you would like to, using this QR code here. So why does timely access to medication matter in end-of-life care at home? So imagine a family calling NHS 111 at night because their loved one is in distress. The nurse can't come right away. The out-of-hours GP doesn't know the patient or their care plan. And the nearest open pharmacy is miles away. Then families may face a difficult choice. Should they go out and leave their loved one in pain at home, or stay at home and risk poorly controlled symptoms? Then, even if the medication is obtained, the nurse may not be available to administer them in time. So getting medication is not simple. It involves 4 key steps: assessment, prescribing, dispensing, and administration. And out of hours, each of these steps becomes harder. When any step fails, families are often left to manage alone and may turn to emergency departments. And that's why a streamlined, well-coordinated system is essential. And in this talk, I will show where delays occur more often and highlight some local solutions that are addressing them. Our aim was to identify system-level challenges and solutions to out-of-hours medication access in community end-of-life care. We conducted structured interviews with professionals overseeing out-of-hours services in the UK. And although the interviews were structured, the participants offered rich qualitative accounts, which we analyzed thematically using NVivo. We spoke with 71 professionals covering 60 geographical areas across all 4 UK nations, as shown here. Many participants had decades of experience in out-of-hours services. Then from these interviews, we identified 4 themes: patient assessment and medication prescribing, dispensing and collecting medications, administering medications, and anticipatory prescribing. This has been mentioned by the earlier presenters, but that is planning ahead so that appropriate medicines are prescribed, collected, and available in the house before they are likely to be needed. So now I'll go through each of these in the next few slides. Assessment and prescribing. These depend heavily on community services that are often overburdened. In many areas, small teams cover large area, leading to long response times, especially out of hours. Another issue is the timely identification of people who need palliative care. Those already known to hospice or specialist teams, they tend to receive quicker support. As one participant put it, if the patient is not known to the hospice, it would be more difficult as the hospice will not have access to medical information and may need to involve an out-of-hours GP, which adds delay. But we also heard about practical local solutions. Some areas involved professionals beyond community teams, for instance, hospice clinicians prescribing remotely after thorough nurse assessment of patients, or specialist teams are available out of hours. In other areas, increasing the number of non-medical prescribers, ensuring timely support, but full access to patient record is essential for them to work effectively. Now, dispensing and collecting medications. So even when a prescription is ready, getting the medication can be difficult. Few pharmacies open 24/7, and safety concerns limit late-night dispensing of controlled medications, as one of the participants described here. They tried to set up an out-of-hours pharmacy rota, but safety and security concerns made it very difficult. Secondly, even designated pharmacies sometimes lack stock of essential end-of-life medications. And thirdly, families may need to travel long distances, sometimes under considerable stress. But some areas have developed solutions. For example, hospital and hospice pharmacies sometimes provide access when local options are closed. And especially in rural areas, one of out-of-hours GPs and paramedics may carry small stock of core end-of-life medications. ready to administer during home visits. And then in several areas, driver services or healthcare professionals support patients and families who cannot travel. And one GP cooperative developed a protocol where medications are picked up from the hospital pharmacy and delivered directly to the patient and administered. So the medication is finally in the house, but the story doesn't end there. Even when medications are available, timely administration can be delayed, especially out of hours. So staffing shortages and covering large geographic areas mean long wait for nurses, and this issue came up repeatedly in many areas. And some areas have introduced protocols for care administration, where family members are trained to give injections themselves. But as this quote shows, it is not suitable for everybody and requires careful screening and training. To reduce delays, some areas have paramedics or rapid response teams who can administer medications when nurses aren't available. We also heard about specialist palliative care paramedic service that provide home visit specifically for patients requiring palliative care. So now moving on to anticipatory prescribing, it is often seen as a solution and it can help, but someone still needs to administer the medication at the right time. One participant told us something really stuck with me, which is anticipatory medications are often in place, but there isn't anyone to give them. Also, access to anticipatory prescribing is mostly limited to patients already identified as palliative, who are often those with cancer. So people with other conditions may be overlooked. And some expressed safety concerns, such as fears of misuse or theft of controlled drugs that can delay in prescribing. So we have seen how each step in accessing medication out of hours can break down. So even small gaps from assessment to administration can cause delays, putting patients and families at risk of avoidable suffering and potentially leading to emergency hospital admissions. Anticipatory prescribing can help, especially up to medication collection, but it is not always sufficient. And that is why we need a whole system approach, not just focusing on one part of the system. So locally appropriate innovations are part of the solution, but they need to be supported by a streamlined system that is connected and responsive even out of hours. Thank you very much, and I'm happy to take questions.
Yumi, thank you ever so much. It's fascinating work, and again, great insights into how this care sits within wider systems of care. So it's very tempting to try and separate things into one system, but a lot of things that happen in the context of quite constrained resources, and that's really useful insights. Thank you. I'd like to open to a Q&A session. Now, we've had quite a few questions put in the chat, so do please keep them coming in if you add them to Q&As. I'm going to bring out some things. I could bring out many. I'm just going to bring out a couple. And one which I think speaks to all of you, so anyone feel free to respond. Natasha Bradley has shared, one of my participants, a bereaved family caregiver for his wife, said to me that he thought it was much easier to get the right medications if you're a pushy middle-class person. He described it was gaming the system. Have any of you come across similar sentiments in your work from patients and families or professionals? Sarah?
I mean, yes, is the short answer. I think there's real recognition amongst patients and carers, and actually amongst professionals as well, that the social capital that you bring by coming from all sorts of places of privilege helps you work any system. And I think and I think we have comments that speak to that throughout our data, and in contrast, comments where people make references. Obviously, people use their own language, and I'm not directly quoting here, but essentially say, you know, I'm not a person like that, and referencing a lack of some form of social capital that makes it harder for them to interact with the system. But equally, even the highly paid, highly educated, often middle class professionals working in the system, you know, made comments about, if I can't make it work, how do we expect anybody else to be able to make it work?
Thank you. Rosanna and then Sally Ann.
Yeah, just to support what Sarah said, really, I think in our work, I don't think we necessarily saw references to whether you've had more social capital, but certainly your ability to make how much energy you had to make the most noise, and the ability to sort of like trying to continually sort of put pressure on systems to try and get things to happen. And we also had a couple of cases where people had had previous experience with other family members and things like that. So that bit of knowledge from other sort of experiences, I was thinking about in the case of Ted, where, you know, Sarah had experience of anticipatory medications, so she knew that they might be a thing that could be prescribed, and that really supported making those things happen for her. So a lot of kind of background and sort of hidden knowledge really made a difference here, I think.
Thank you. And Sally Ann?
Really picking up on both what Sarah and Rosanna said, when Rosanna's just mentioned hidden knowledge, but it's the hidden work element of our research study that really exposes these activities and involvement that people use, and these hidden systems in order to just achieve, whether it's medicine supply or what to do with them. The number of times that people mentioned legacy COVID WhatsApp groups for their local street or village, and how they posted questions on that, or even asked for supplies of medicines they couldn't get hold of, that was happening. And so what you find is that people will find a way around, albeit not conventional. So it's a case of trying to bring people into the system so we can, you know, respond to patient safety and patient confidence with meds, but the system's got to respond.
Thank you. It is about social capital, isn't it? Even if you're the most able, articulate person, you can still struggle with this system. Irene's left a comment or question. Firstly, says fascinating presentations. Thank you all. I'm curious about the role of unpaid carers, and in both groups in how they struggled almost universally across the studies. Carers often have a number of roles. Do you think recognising them for their role in medicines and better supporting them might have some beneficial knock-on effects? Celia.
Well, definitely. You know, at the end of the day, when the front door closes, and if somebody has a carer living with them, that's who's left with the patient, the symptoms, the medicines, whether there's access to the medicines or not. And I think one thing that the system is poor at is when somebody's admitted to hospital, is that they don't maintain the carer on that journey with the patient, with the information, with the decision making, what happens next when people go home. And it's often a case of that the care is excluded through the duration of the admission, and then at the point of discharge you pick up with a carrier bag of medicines. And so it really is thinking about how can we have an integral system that takes the carer with the patient's permission all the way through that system as a whole.
Thank you. And Sarah?
Yeah, just to add that I think what's really critical is that we look at the systematic factors. So in policy, protocol, guidelines, institutionals, risk assessments, and actually the training of healthcare professionals, how we change our, and I speak as a doctor, our own attitudes and behaviours to be more inclusive of carers. Obviously, we have to work within a system that legally the patient is entitled to confidentiality, but when they've clearly said they want this person to be a partner in their care, I'm just really keen that we try and take that stance and change ourselves, if you like, as insiders in the system, rather than it being perceived as, oh, we could train carers to do their stuff better. They actually know very well how to do their stuff. It's our problem, not their problem. And I think that's critical. And across many of my studies, not just the one we've shared today, carers talk about how when somebody is not in an institution, be that a hospice or a hospital, they are just left to have complete responsibility if the person can't manage things themselves. And yet, as soon as they turn up to institutional doors, they feel like they're treated as part of the problem. That maybe if they'd done better, that person wouldn't needed to have come into hospital particularly. But even in the hospice, you saw in my quote example, the person felt like they were being treated with suspicion, that how could their list be more accurate than the hospital record? Yet no healthcare professional would ever 100% trust a hospital record that was a few months out of date on someone's medicines.
Thank you. I'm going to slightly change the question that's been asked. So Joanne Wilson has taken, from the care home perspective, we support many residents at the end of life. And often these people, the residents they care for, aren't admitted. And during COVID, there was policy across the UK which allowed the repurposing of controlled medications, anticipatory medications, for one person to be repurposed for use for somebody else with a new prescription. And Joanne has said this was really useful, but now we're back in a situation where actually perfectly good medication are thrown away. Do you think there might be a change in legislation? And my question is, do you have a particular stance from your research point of views of actually would it be helpful if care homes could hold a central stock of medication? Rosanna.
I guess what I just wanted to add to that, I was how concerned often carers and things were about unused medications that then need to sort of be disposed of afterwards. And it was something that's cropped up a lot in the research that we've done, and a sort of like a real disappointment that that's the case. Not only is there complexity of actually them having to dispose of it, which is a whole other area of need that needs to be looked at, but also that is knowing that medications are being wasted. And so I guess one of the ways that that could be done is in exactly those situations in care homes where those medications could be repurposed. I would imagine that would be something that would certainly be supported.
Thank you. Sally-Ann, you give your last rights for comments, and then we're going to bring Morag in.
So just following on from Rosanna's point there, some of the impact work that we carried out with our toolkit was working with the team in Glasgow, and the hospice staff, they were very concerned that at the point of somebody's admission, they were bringing enormous amounts of medicines, and that would take nursing time away from caring for the patient and the family at the time of admission, because they had to book all the CDs in, etc. And so they did their quality improvement project around that, about advising patients about what to bring in, but then started conversation with community colleagues who, in their opinion, were over-prescribing. So it is about moving across those boundaries and thinking about the quantities that are being prescribed. And so perhaps your suggestion of having a more available stock would be helpful.
Thank you. There's so many questions and comments people in chat. There's a really nice feed going. So I just wanted to flag that. And what we'll do is we pull the chat if it's okay, colleagues who are supporting us, and potentially if our presenters are happy to pick up on some of those answers, because I think there's something quite specific for people in that chat. I just wanted to say a great virtual round of applause. Thank you ever so much for 3 fascinating presentations and 3 excellent complementary sets of work as well. So thank you. And over to Morag.
Fantastic. Thank you, Ben. So I'm just going to share very briefly 2 very quick slides to let you know about forthcoming webinars that's coming up. So the next webinar is on palliative and end-of-life care for people with neurodegenerative conditions, organised in collaboration with the NIHR ARC Policy Research Unit in Dementia and Neurodegeneration in Exeter, and the NIHR PRU in Palliative and End-of-Life Care. And that's on the 29th of October at 11 AM. And I think Nick's put some links in the chat to help you access booking for that. And then also just a plea to give us evaluation and feedback. If you click on this link or use the QR code, or again follow links that Nick's put in the chat, you can let us know your thoughts on today's webinar and any comments and suggestions for our other webinars going forward. So thank you everyone for an amazing session, fantastic chat and points in the Q&A, so please do access them, and everybody have a really great day.